But we do have a new navigator, Brittany Fox Standing, and Brittany's on the line, I see. So, and in front of you, Chelsea has displayed the agenda. So really it's just kind of getting to know each other a little bit more, reviewing the charter. Although this won't be news to you, we can show you all the cohort sites that we have and how much money we've distributed to date. You guys are really familiar with the toolkit and the reporting workbook, but you might not be as familiar with the CSI dashboard that we've been working on. And then Lauren's going to take us through the GCCM model. So we're now calling it the Greater Columbia Cares model because we're pulling from so many different resources, and Brittany can probably talk a little bit about that too. But Brittany, since you're on the line, why don't you introduce yourself and tell everybody a little bit about you, and then you can hear from Deb, and we can hear from Rick, and then we'll maybe have Philip on the line by then.
All right, great. Greater Columbia ACH. I think this is my 3rd week. So pretty brand new, just working on my training right now. I was a clinic manager there for about 4 years, managing their urgent care and their primary care clinics. So I'm on the other side of the practice transformation over on that end, being at the practice that's trying to implement the changes, which I'm hoping will be very beneficial to Greater Columbia and being able to help some of the other clinics. A little bit more of my background: I've been in healthcare for over 15 years and have done a wide array of things. I've actually worked in nursing homes, I've worked in the hospital setting, I've worked in clinics, and I've actually, I have a very extensive pharmacy background as well. So very well-rounded in the healthcare and the direct care to go to patients. So all of that I think is going to be really great for helping me be a good practice transformation navigator. So very excited to be here.
And Brittany, don't you have your MBA?
I do. I have a bachelor's degree in operations and project management, and then I also just finished my MBA from Washington State University last year.
Cool. So Deb and Rick, do you guys want to share a little bit about yourselves with Brittany? And then I've asked Lauren, or Chelsea's going to pull up Brittany's picture that's in our GCACH report so you can see what Brittany looks like.
That'd be great. So this is Deb Watson. I am a nurse, been a nurse for a long time and worked in all kinds of settings, mostly in the hospital, but within, I guess, different service lines. And I am currently working at Pullman Regional Hospital as a clinical project manager. So I started in the quality world almost 20 years ago. And so I'm helping the Pullman community with their practice transformation efforts. And I am doing all the data collection and helping the hospital and the Pullman Family Medicine Clinic move all the milestones forward. So that's kind of me in a nutshell. And I'm also a part of the Whitman County Health Network team.
And I think, is Martine your navigator, Deb?
Well, Jenna was the navigator, so I'm guessing that Brittany may be our new navigator.
Oh, okay.
But I don't really know.
Do you know Brittany?
We're actually scheduled to have a meeting to go over that with Sam tomorrow. So I'm not quite sure if it's going to be me or if it's going to be Martin. I would think it was going to be me, but I won't know for sure until tomorrow.
Okay. All right. Do we have a picture of Brittany that we can show everybody?
I'm almost there. My computer, of course, was freezing there for a moment.
Oh, okay. Well, no problem. No problem.
I got it right now. Here's a grand showing. Oh, here it comes. And
drum roll.
Boom. There's Brittany.
There we go.
There she is.
And Brittany, you never said anything about what's going to be happening. Is it October?
Oh yes. So I am pregnant, and I'm due in October. So very fun, exciting time.
Congratulations.
Thank you.
So that's our lovely new navigator. So Rick, do you want to tell us a little bit about yourself?
Sure. My name is Rick George. I am a director, administrator with Comprehensive Healthcare. This is my 3rd year with them. I worked in Oregon for 5 or 6 years, but most of my time was in Illinois. I worked in Illinois in a variety of settings: mental health, substance use. Ran a large substance use facility there. Was hired on by Comprehensive to be sort of the lead person to integrated care as we stepped into this sort of new contracting phase. We just went through a restructuring where we now have a lead to each of the contracts themselves. So of the 3 contracts we have with Greater Columbia, we have a lead to each of those. And I have a sort of a dotted line matrix relationship in working with them as they move forward with the milestones at our respective sites. So I will continue to stay involved and continue in a role with Greater Columbia, sort of at a higher level, similar to what Ed Thornrue did as a role with the team. So
Great. Unfortunately, we don't have a picture of you, Rick, that we could show Brittany. But
okay, well, that's too bad because I'm very handsome today. So just think handsome, and that'll be good. So.
You are a handsome guy. So
there you go.
And I don't know if we have Philip on the line yet.
I don't.
Probably not.
I'm not.
Okay. Well, you guys are pretty familiar with Greater Columbia and practice transformation, but let's put up the charter, Becky or Chelsea, and we'll just kind of briefly highlight, the charter. So, obviously our practice transformation team is the heart of what Greater Columbia is trying to do with respect to the Medicaid waiver, which is to improve the healthcare delivery system. And when we brought Sam Wardell on board, she had a very strong background in practice transformation and has done PCMH in different states across the nation. And her depth of experience really led us down this path of working within clinics to help improve work processes and workflows. So the practice transformation work group then is the kind of the monitoring and the evaluation arm for Greater Columbia to ensure that the projects and programs that we have going are helping us meet the Medicaid waiver goals, which is obviously the kind of the part of the triple aim, with the biggest emphasis on bidirectional integration. And then, of course, there's the 2 project areas that are mandatory: bidirectional integration and the opioid work group. So really the practice transformation team is helping us with strategy and engaging leaders. And last year when Becky and Wes and Sam and I went around and met with all of you guys, you actually helped refer some new organizations into our mix. And that's where we got cohort 3 from, was some kind of this referral network. So the purpose that Chelsea has on the screen is reviewing data, making sure that we have the appropriate selection criteria for the providers. So not all providers get to be in the program. There has to be a really strong leadership component at each one of the organizations that is top down. The leaders have to believe in cultural change, because that's what it takes in order to change an organization, is strong leadership with a willingness to change the culture of the organization. I already talked about selecting providers. So the first 2 cohorts, we had a very strong selection criteria that went through an independent evaluator. The 3rd cohort was a little bit different of a mix, and so Sam had to score all of those organizations, and some of the larger Medicaid providers did get a 3rd site that we added to cohort 3. And then you help us identify regional strengths and weaknesses to better inform the selection of the providers, and then you help monitor the progress of all of the sites. And I just realized, I apologize, I did not ask any other staff to introduce themselves, so I'm going to stop right here and allow other staff members that have joined us to introduce themselves. And I apologize, I really jumped the gun on that. So we've got Wes, Lauren, and Becky, in addition to Brittany on the line, and Chelsea too. So why don't you go, Becky? We'll go in alphabetical order.
Okay, great. Hello, everybody. Rick and Deb, I haven't talked to you guys in a long time. This is Becky. I'm the Director of Finance and Contracts, and you both know. Hope you're doing well. It's nice to chat with you.
Chelsea, you'd be next.
Oh yeah, sorry, I was thinking Brittany, but she obviously already introduced herself. I'm Chelsea. I am the administrative assistant and the person driving the screen.
And I'm Wes Lucky. I've met both of you. I'm the deputy director.
Hello, this is Lauren Noble. I am the marketing manager for GCACH.
And did I forget anybody else? I apologize, you guys.
I think that's it.
Okay, all right. So we do, you know, in the charter, we did make sure that the principles of this group were emphasized, so that we really want to get various sectors and domains involved in the practice transformation work group. It's really a reflection of the board of directors. It's a reflection of the sectors that make up the Greater Columbia ACH. And that we want to ensure that we address certain target populations and acknowledge disparities in health equity. And as we select our providers across the region, we try to make sure that there's geographic distribution of not only the funding, which Becky's going to show you in a little bit, but of the places where we're doing practice transformation. We try to provide timely review and feedback on all of the reporting documents. I know that Sam and Brittany and the navigators get lots of questions from the providers, so we try to respond quickly to those. You guys are kind of the ambassadors. We call you the disciples of change within your organizations, not just the leadership, but we specifically select people to be on the practice transformation work group because we know at certain times during the life of the organization things change, and we might need to call on you to get through the front door to your CEO or to other people, or to make certain connections. And that, of course, you support the vision and the mission of GCACH. And the appointment process is pretty formal because your organization is paid for your participation in Greater Columbia ACH, and we go through a careful vetting process to determine who can actually sit on the practice transformation work group. Initially, there was a lot of meetings to get this set up, so we were meeting twice a month. So it was a pretty intense year in 2018 to get set up, and then the meetings have tapered off, and now they're just quarterly following the reporting cycle, so it's not quite as intense. But you have certain subject matter expertise that you bring to bear that we really appreciate, and a lot of times we'll filter changes to the dashboard or the workbook through the practice transformation work group. We did that last year, so there was a little bit more time and effort regarding that. The PTW was chaired by a dyad leadership. It used to be Brian Sandoval from Yakima Valley Farm Workers and Mark Wakai, who is Vice President of Providence. I think he's doing population health. And we still haven't found another co-leader, so we'll be reaching out, I guess, to the group. Is it next week we have our actual meeting, Chelsea?
It's
to find
following. It's on the 4th, so
okay.
It's not next Thursday, but the following.
Okay, so we'll have to figure out who would like to be the co-leader. It's just nice having two leaders in this as part of this work group, because inevitably somebody can't attend, and it's nice to have a leadership among your peers. So there's the list of the 12 to 17 members. I think we have 16 on the work group now, and again, in all of these different sector and areas. So we've got anywhere from Dan Ferguson representing workforce, and I think it's still Jorge and Kat Late from MCOs, and so we've got expertise in all of these different areas. Obviously, Rick, you're into the behavioral health, mental health field, and Deb with primary care. So, and then these are just our administrative duties. And I didn't know, Wes, did you want to bring up and talk about the QI strategy and how it relates to the practice transformation work group?
Sure. Chelsea, do you want to go ahead and give me the screen for just a second here? So can you all see this?
Yes.
Yeah.
Yeah.
Okay, hang on just a second here. Let me see if I can do something. There we go. So this is a model that we put together for one of the semi-annual reports that we're required to submit to the independent assessor, which is Myers and Stauffer. So this is part of the pay for reporting component of our work, by which we receive the funds that we distribute to our provider organizations. We put together a quality improvement strategy document. Actually, Carol put it together. And we tied in this diagram that talks about a component of the quality improvement plan. But it's nice because it sort of rolls up some of the fundamental work of the practice transformation work group. And so I'm just going to kind of walk through what the document says. There are 8 change concepts that are tied to our work, and I think Carol may touch on these later, but these change concepts translate into some practice transformation resources. The most important of which is the Practice Transformation Toolkit, and I think you've all seen this document before. We also rely on learning collaboratives, which include our Practice Transformation Provider Organization. We leverage the skills and ability of our exemplar organizations, such as Yakima Valley Farm Workers and other organizations. Technical assistance that comes from our Practice Transformation Navigators, including Martine, Brittany, Laurel, and managed by Sam. We also have a healthcare communities portal resource site. It's being hosted for us by CSI. We'll take a look at that, and one component of that is the dashboard. There's also practice transformation implementation work plans that each organization puts together in collaboration with the Practice Transformation Navigator to sort of chart out and monitor the progress of individual organizations. And we also do assessments. So the toolkit in this example talks about the quality improvement strategy, but again, the toolkit has a number of milestones. This feeds into the individual practice transformation organization and their work, including their quality improvement committee, which typically manages the practice transformation process. It's overseen by leadership, clinical staff becomes involved, and the administrative staff becomes involved. Now, continuous improvement and quality improvement is really a fundamental piece of practice transformation. And in fact, without this, the process really doesn't happen. So internally within each of the organizations, they go through the PDSA cycle, which I think we're all familiar with. The results of that come through to us through the milestone reporting, which happens the month after the end of an individual quarter, which we just finished closing out for first quarter of this year. So the practice transformation organizations upload their milestone reporting deliverables to us through that CSI platform that I just mentioned. They also upload their CQMs, their clinical quality metrics. That's a term that's used by the the CPC framework, which comes into our practice transformation toolkit. Essentially, CQMs are these pay-for-performance measures, which we are now held accountable to. Last year, 25% of our payment came from the performance that we achieved on pay-for-performance measures. This year, it's 50%. Next year, it's 75%. And those pay-for-performance measures roll up the performance, not just for our practice transformation organizations and the Medicaid clients and beneficiaries that they see, but for all of Medicaid within the 9-county region. So being successful in CQM at the organization level translates to success overall. So that's really an important part. So then that feeds into what your responsibilities will include, which is the practice transformation work group review. Sorry, get that off of there. So the practice transformation work group reviews the milestone reporting. Martine has done a great job in putting that together into a matrix diagram or a table. Obstacles to practice transformation implementation are assessed by the practice transformation work group, and possible solutions are identified. This translates and comes back out and adjusts our work to help overcome some of those obstacles. And then that goes back into the practice transformation organizations. So you can see here, there's somewhat of a cycle that goes through that's based on the work and the review work that you'll be doing. And I'll stop there.
Thanks, Wes. Any questions, Deb or Rick?
Yes, I have questions.
Sure.
So the last part of Wes Lucky's presentation talks about the role of the work group participants in oversight to, it sounds like, each of the quarterly reports. Now, as far as I can tell, there's a lot of quarterly reports that get submitted. Like how many? 60?
83 now.
83. Yeah. So what is the workload responsibility as a member of this team for that oversight to those reports?
Well, we are happy to announce that it's not much because we have digitized all of the results of the reports, and in just a few minutes we're going to have Wes take you through what you will be looking at that makes your life a lot easier with regard to oversight of the sites.
You know, in general, it's pretty. I don't want to say it's rubber stamp. A lot of the organizations pass through the review process without a second thought because they've all achieved the milestones. What we tend to focus on are perhaps those organizations that might be set back or struggling for a particular reason or another. There's some discussion about that. And then overall, as I just mentioned, a big part of the conversation is around some of the obstacles. For example, EHR implementations. If it's happening in a behavioral health practice, that can be a real obstacle to achieving some of this work. So in general, that's really the big part of the discussion. If we went through every single one of those 83 organizations in detail and looked at all their reporting, I mean, we would be there for 3 days. So that's, I appreciate
the conversation in that it sounds certainly like a high level review and somebody else is crunching the numbers for that to be a process. So, right? So that sounds good. I'll withhold. I'll refrain on my question for now and then see how it looks when we get to the report looks like.
Okay.
Greg. So Becky is going to take us through the sites and a little bit about the funding to give you guys a high level overview of that. So Chelsea, I guess we'll have to put up the list of sites.
Am I doing the sites or the payment?
Well, why don't you do the payment and we can do the sites if you want to, Becky. I know you have to,
Okay.
you have a meeting at 11:30.
It's okay. I can do both, but
Okay, all right.
yeah. All right, cool. So the spreadsheet that Chelsea has up on the screen shows the payments that we have sent out for cohort 1, which was our first round of practice transformation work, and then cohort 2, which was our first round of IMC work, which actually happened in 2018. And then cohort 2 is second round of IMC work for our behavioral health providers. And then cohort 3 are the additional sites that we added that we didn't work with in cohort 1. Some of them are new skilled nursing facilities, some of them are new practices and a hospital, and then some of them are hospitals that we had contracted with cohort 1, but we allowed them to bring on new clinics for cohort 3. So we broke it down by county. This is a spreadsheet that we've given to some of our local government that we've been talking to about our work. And so we broke it down by county so that when we talk to the state representatives, they could see how much money we are putting into their own counties. So for you guys as well, you can see how much we have put into your respective counties. So is there anything else you wanted me to say about that, Carol?
Do they have any, so the difference between cohort 2 IMC, so cohort 2 is basically the behavioral health providers. Comprehensive is actually in cohort 1 because you are a big player within all of the different counties, and so we wanted to make sure that you were in cohort 1, but you're also participating as a behavioral health provider and getting funding through the integrated managed care transition. So that the IMC is really talking about the funding that came out of the integrated managed care initiative, and then we rolled all of the behavioral health providers into cohort 2. So cohort 2 are actually practice transformation payments, even though they're coming out of the IMC fund. I don't know if that makes any sense, but it's a little confusing when you see cohort 2 twice.
Yeah, that's what I wanted to talk to you about, Carol. I think that we should change it to IMC year 1 and IMC year 2, just for the spreadsheet purposes.
All right.
I think it's confusing too.
But you can see the lion's share of funding is going to Yakima County because honestly, you guys have the lion's share of Medicaid population.
Right, that's correct. So
let's oh, go ahead, Rick.
This is a hard thing to explain. I agree. You guys have not made it simple to interpret this information. But I understand it. I understand it in principle. What you're trying to do.
Okay.
So Rick, just out of curiosity, where are you struggling to understand this in a general sense?
Well, just the issue that you have 2 cohort 2s, and then one of them is an IMC piece. And I guess let me kind of describe another challenge that it dovetails with this. So when I look at the budgets for each of the contracts that we have, those budgets have a real simple table spreadsheet of required activities, and a simple one to think about is HR recruitment and retention. It's a category of how the budget lays out. Then when we get into the milestones, the way in which you guys are paying us for the milestones is significantly, it doesn't line up perfectly with the way that initial budget is on how we're working going forward and how the milestones are then being paid back going on a quarterly basis. Does that concern make sense to you?
You know, it does, and I think there's a reason for that, in that not every organization is at the same point in terms of the traveling towards the patient-centered medical home. Some organizations are much farther along. Farm Workers is a great example, is an exemplar organization. They do many, many things right to achieve that. Other organizations, to be honest, such as primary care practices that are affiliated with hospitals, are much less farther along in this process. So depending on where they're at along that continuum, their allocation of funds are going to be different, and the types of areas that they apply those funds are going to be different. So just to say that funds will go to all of the milestones areas equally would probably not be the most efficient allocation of those dollars, because it wouldn't necessarily align with what the organization's individual needs are.
Yeah, well, I'm not looking for a perfect match, one for one kind of match, but I do think that the way in which the language is used in the initial budget and the language is used and the way in which we're being paid for performance by quarter, they don't line up. It's like we're looking at two different things, and I'd prefer it look more similar than different, and have a definition of those things be more similar than different.
Hi, Rick, this is Becky. I just wanted to ask a clarifying question about what you're saying. So you're talking about the budget that you have to submit as one of your milestones?
Milestone 1 has the budget sheet in it. And at the end of each year, then you reconcile that budget with the second portion of milestone 1. That language in the budget of how we've spent the money does not line up well with the way we report on milestones and the way in which we get paid for milestones.
Okay, I hear what you're saying. So do you have a recommendation of what we could do to change the budget, the language in the budget template? And honestly, it's just a template. You don't have to use it. I don't know.
Right. I don't think we thought very much about whether we should or shouldn't use it. We just used it. So, but in hindsight now, I guess what I would really like to think about is, we didn't do as much definition of what those budgetary categories represent, and you didn't provide us very much definition of what those budgetary categories meant. So now we're trying to figure out, well, what the heck did we mean there? So.
Well, and that was by design. To be honest, we don't want to dictate how you use that money. We want to dictate how you earn the money, to make sure that you're doing the practice transformation work, but how that money is spent, we didn't want to really have our fingers in that. So we kind of did that on purpose.
And I would confirm exactly what Becky is saying, Rick, is that we don't expect there to be alignment necessarily. We just know that there's certain things that have to be done to accomplish milestones, but the budget and the way that you spend the money can be very different from the way that you earn the money. So let's say, for example, you earned money for bidirectional integration. You might take the funding that it comes through the portal labeled bidirectional integration and use it to, I don't know, purchase an addition to your EHR. We don't really care. We just care that you're going through the program and implementing some of these evidence-based practices and processes for your organization.
Well, I appreciate that. And I appreciate the conversation around this, because I think that helps us. I think some of this for me is just hindsight as to what is the, I have to tell you that if we had known that we had a broader discretion around how to define the budget for this going forward, I think we would have spent more time on it. That wasn't clear to me, and I don't know if it was clear to anybody else in our organization around how much discretion we had to move those, define those categories differently.
I'm sorry.
Okay. Yeah, I apologize for that.
Sorry.
I'm trying to remember who from your organization came to our kickoff meeting, because every year that we start a new cohort, we have a big meeting and it's focused on the budget. And so I can't remember who from your organization came. But that's really when we have those conversations with everybody, and I'm there and I'm sitting at the table with people, helping them talk to them about their budget, answering their questions. So I can't remember who came from comprehensive though.
I don't remember either. Sam might be able to recall.
I think what matters is how do we go forward from here? That's what I'm interested in. So
Sure.
I think knowing that we have a lot more discretion around how we define that, I think is helpful. We have another year and a half of activity along these lines. So
that's great. Good. And Rick, honestly, if you or anybody on your team have any questions about that budget, please reach out to me. I'm happy to answer questions. I don't want you guys to be struggling through, muddy waters when we could maybe clear it up a little bit.
Great, thank you.
So, yeah, one of our overall intentions is to build in quite a bit of flexibility into this program. One of our practice transformation providers said that you are, what is it, prescriptive without being descriptive, or descriptive without being too prescriptive.
Yeah, that was Scott. That was Scott Adams.
Yeah, which really kind of summarizes, you know, what we're trying to achieve. We do have the toolkit to sort of outline what needs to be done, but without being too overbearing, given the fact that, you know, different organizations proceed through this process differently, and their implementations are all going to be unique. So, I mean, I think that's, you know, that's a big part of how we're trying to put forward this model.
This is Deb, and if I might add, I am so appreciative of the flexibility, because I know for the Pullman community, you know, we actually changed some of the focus of some of the budget money, and I just ran it by Jenna to make sure that it still fit within the guidelines before doing it, but those were really helpful changes to us.
Great. Yeah, it's once you guys get the money, I mean, it's really up to you guys to figure out how you want to use it to meet the milestones. And it might not have any relationship to the way that you want to meet the milestones and the funding you get for certain categories. So that's the beauty of the program.
Yes, thank you.
So Becky, I think the next thing is just to take a look at the cohort sites.
Sure.
Okay.
Yep, I can do that, and then I need to jump off.
Okay.
Okay, so this list is kind of interesting, because I think, to me it is, because you can see where some of our provider sites overlap in our different cohorts. And then there's also the column C that talks about what provider type they are. And this is a list that Wes downloaded directly from our CSI portal, which I think is pretty cool. That portal is really powerful. So we get, just kind of scroll through the list. I think Chelsea gave everybody kind of an idea of, I think, the breadth of the different types of provider organizations that we're working with. And you can see there's primary care, substance use, hospital. We just brought on some skilled nursing facilities, which is pretty exciting. We have dental. I think that we really are covering a large variety of different provider types. And then it shows you all the cohorts that they're in. So you can, I mean, Yakima Valley Farm Workers right there, you can see that they're in all three of our cohorts. So they're a really good partner agency for us. Is there any questions about this, or anything Carol or Wes you want to add?
I would just point out for columns B and C, where it says the cohort and that type, such as substance use disorder, will play out in something we'll talk about here in a few minutes with the dashboard. We also, and I'll stop there.
You guys have any questions, Deb or Rick?
No, I don't.
No, thank you.
Okay. So you guys.
Thank you, guys. I'm going to have to jump off.
Okay.
It was nice chatting with you, and please reach out to either one of you if you guys have questions about your budgets or the contracts or anything I can do to help.
Thanks, Becky.
Thank you.
You guys are very familiar with these next two things, the GCCM toolkit and reporting workbook. I think, so why don't we do this? Why don't we have Lauren explain the GCCM model, since it has a nice introduction really to the toolkit and the reporting workbook. So Lauren, do you want to go ahead and explain our new model?
Sure, I'd be happy to. So for GCACH, the patient-centered medical home model of care is the foundation for practice transformation. But it's not all that our practice transformation team delivers to our partnering providers. Based upon several initiatives and evidence-based care models, our team realized that we had designed our own model of care and came up with the Greater Columbia Cares model, which Carol will be, as she mentioned, going through the toolkit and workbook. This model incorporates best practices from the Institute for Healthcare Improvement, or IHI, the Comprehensive Primary Care Initiative, 6 building blocks, the Safety Net Medical Home, the Agency for Healthcare Research and Quality, and the Robert Wood Johnson Foundation's Culture of Health. So IHI takes a unique approach to working with health systems, countries, and other organizations on improving quality, safety, and value in healthcare. This approach is called the science of improvement. The science of improvement is an applied science that emphasizes innovation, rapid cycle testing in the field, and spread in order to generate learning about what changes in which context produce improvements. It's characterized by the combination of expert subject knowledge with improvement methods and tools. It's also multidisciplinary in the fact that it's drawing on clinical science, systems theory, psychology, statistics, and other fields. Before I move on, Carol West, is there anything you want to add about IHI?
Nope.
Okay, great. Next is the Comprehensive Primary Care Initiative, or CPCI. CPCI supports the provision of a core set of 5 comprehensive primary care functions. This includes risk stratified care management, access and continuity, planned care for chronic conditions, and preventative care, patient and caregiver engagement, and coordination of care. Next is 6 building blocks. The practice transformation team is trained to deliver a structured, system-based approach for improving management of patients on chronic opioid therapy called the 6 building blocks. The blocks include demonstrating leadership, support, and consensus, revising and implementing policies, patient agreements and workflows, proactively tracking and monitoring patient care, implementing planned patient care visits, developing resources to care for complex patients, and measuring implementation success. Next is the Safety Net Medical Home. The patient-centered medical home model of care is a model of primary care delivery. In PCMH practices, patients receive well-coordinated services and enhanced access to a care team. I think both Rick and Deb are very familiar with this, as we've been using PCMH as really the core of our work. Next is the Robert Wood Johnson Foundation. The Robert Wood Johnson Foundation's Culture of Health Action Framework strives to improve health, equity, and well-being. Informed by rigorous research on the multiple factors which affect health, it recognizes there are many ways to build a culture of health and provide numerous entry points for all types of organizations to get involved. Lastly is the Agency for Healthcare Research and Quality. It is the lead federal agency charged with improving the safety and quality of America's healthcare system. The AHRQ develops the knowledge, tools, and data needed to improve the healthcare system and helps Americans, healthcare professionals, and policymakers make informed health decisions. So we're really excited to introduce the Greater Columbia Cares model. As I stated, we started with PCMH, and it slowly evolved to incorporate all these great evidence-based care models and initiatives, and we're excited to move forward with this new model of care. Carol West, anything to add?
I'll just say here that all these components for the GCCM model aren't necessarily exclusive, in that the chronic care model, which came out of the Group Health Research Institute back in the mid-90s, carries through a lot of these different components: the Safety Net Medical Home Initiative, the Patient-Centered Medical Home, the Comprehensive Care Initiative. It's really fundamental to all those. So a lot of these build on each other to come up with this comprehensive model for carrying out our work.
And the only thing I'm going to say is that we are just kind of perplexed why the state of Washington just didn't use the patient-centered medical home model of care to deliver all of the 8 projects, because really they all fall under the umbrella of being a patient-centered medical home, you know, which is bidirectional and incorporates team-based, you know, team-based care. It coordinates the care of patients, including helping arrange for MAT treatment. It coordinates transitions of care. It manages chronic diseases. I mean, everything that a patient-centered medical home model of care does is what is in the Medicaid waiver. It's just the way that the state put it together. Some states like Oregon did use patient-centered medical home as their foundational model of transformation. And as a safety net medical organization, like FQHCs are all safety net organizations. They were all into PCMH way before our hospital systems and our clinical systems were. So that's why the FQHCs are so, I think, familiar with this model. And Rhonda Huff made a comment during I think it was a practice transformation work group meeting, one of the very first ones. She said, I want to be revolutionary, not evolutionary, because she didn't think that this was very revolutionary approach to practice transformation, but it actually is a foundational piece, and why most of the FQHCs are safety net and familiar with PCMH. But
you know, another important part of our history is that when we began this process back in 2017, there's a total of 8 project areas that every ACH could choose from, and we originally started with 8. Using feedback from our leadership council and the provider organizations that sat on that, but 8 individual models to implement something or some things is terribly complicated. And so we understood that population health management was really fundamental to our work. And we also understood that focusing on high cost, high risk, high utilizing what we call multi-visit patients was really important, but we couldn't quite get it together into a portfolio approach. So Health Management Associates, HMA, helped us to write our project plan back in 17, and they also worked with us to say, okay, these 4 project areas, which included bidirectional integration, which was required, and addressing the opioid crisis, which was also required, as well as transitional care and chronic disease prevention and control, all kind of aligned in a way to come under a single portfolio. The other project areas, including maternal and child health, oral health, coordination of care, which was very specific and had some reasons. We had some reasons for not choosing that, as well as managing emergency utilization. We focused on these 4 models that really came under this portfolio, and at the same time, we were just so fortunate that, again, Sam came on board, and she had a mechanism and a methodology for implementing those 4 project areas into the practice transformation organizations. So this all kind of came about through guidance from some outside help and from the work of Sam.
any questions, Deb and Rick?
None for me, thank you.
Great.
No, I'm good for now.
Okay, let's talk a little bit about the dashboard. So I think you're gonna have to give the screen to Wes, Chelsea.
Can you guys see my screen? It has the front page of the healthcare community for GCACH.
Yep.
Yes.
Yes.
Okay, so great. So practice transformation organizations are given access and permissions to come into this site. And again, you both may be very familiar with this, but they come in here to the reporting piece, the reporting portal, to upload data. A while back, we talked about coming up with a way to profile and model the information that we were collecting from our practice transformation organizations. Part of that work was to feed this information back to the practice transformation work group, which you're now part of. Part of that supports the practice transformation organizations who can do some benchmarking to compare how do they sit relative to other organizations that are similar in type to them. And it's also useful for internal use by the Greater Columbia as we seek to understand how the process is unfolding and the progress that's being made. So we've worked with CSI, the vendor to the portal, the IT vendor to the portal. And this has been going on for quite a few months to put together a dashboard tool. And this is what the tool looks like. This is actually after some recent changes, which we've just gone through over the last week or so. But the model includes quite a bit of information that we believe is going to be very useful. And I'll just highlight some of these areas, and if you have questions, we can go through those. So here, there's a counter that counts the number of sites. Actually, before I go on to that, let me describe here in the middle, there's a center console that users can select to highlight a particular cohort. If you remember Becky's list of practice transformation organizations, there was a type assigned to each organization in a cohort. Excuse me. Using this tool, the user for the dashboard can select among the cohorts, they can select among the types, and they also can select among the sites. We made a conscious decision not to put site names in here for confidentiality, but we assigned each of the 83 practice transformation sites a number. So individuals can go in here and select their number to be able to discern how their organization is performing across time and across these different measures. The final selector here in the cohort relates to the practice transformation quarter. And let me see if I have that open. So can you see this little table on my screen? It might be a little hard to see.
Yes, I can.
So here we have, thanks, Rick. So we have 2 years, 2019, 2020. And as you can see here, there's a lag. So the cohort one, which was the very big initial cohort, started in January. The practice transformation year one, quarter one were the first 3 months, quarter two are the next 3, and on and on and on. Cohort two, which are primarily behavioral health organizations, started 6 months later, and then cohort 3, which is a mix of organizations, began at the beginning of this year. So there's a lag here, but we realized that if somebody was to select, say for example, in the dashboard, they chose to look at first quarter of 2020, and they looked at all the cohorts combined as a massive roll-up, it would be misleading because the first cohort is beginning its 5th quarter, the second cohort is beginning its 3rd quarter, and the first cohort is just starting. So to evaluate that quarter and those 3 different cohorts in different stages of development would have given information that might have been a bit confusing. So what we did with the dashboard was to align the practice transformation year and the quarter. So as you see here, P1, Q1, P1, Q1, P1, Q1. So going back to the dashboard here, the practice transformation organization can select among those practice transformation years and quarters to highlight performance. Now, when you make a selection, and the dashboard is still a bit under development, they're trying to clean up a couple of issues, but once they select a quarter, they can look at a time series to see how the particular organization, the particular type of organization, or the entire cohort is performing over time. So I know that's a lot of information. Let me pause there for just a second to see if anybody has any questions about the console.
So you just make this available to us, and we can just mess around with it and figure out how it works for us. It looks like it's pretty straightforward in terms of how it moves the data.
Well, we'll do a little bit more, Rick. We're also working on a user's guide that will go along with this, that will give background information for every one of these measures. It'll also give some examples about how to operate the console, which is console is a little tricky in terms of it feeding into these counters up here. The number of sites, the number of active patients, the number of PCP team panels. Initially, when we did the dashboard, we found that these counters were summing up across multiple quarters. So they were like double, triple, quadruple counting. So we fixed that. Again, in the user guide that comes out, we'll come up with some scenarios to show some different console selections to produce data to help the user.
Okay.
I think the important thing is for the practice transformation work group is that it's pretty clear to see. Let's take example, the follow-up within 72 hours of hospital discharge, that graph that's on near the bottom. You can see how we have improved across all of our cohorts with that follow-up, and that's a pay for performance measure. Same thing, a follow-up within 1 week of emergency department discharge. So before it was really, we would have to look at a whole bunch of different organizations, or would have to just get a report from the practice transformation work team about how well each cohort was performing. This allows us to go in by cohort, or you could even look by site to look at how well an organization, a cohort, or all three cohorts are doing across time. And so we're really proud of this. Now, if you look at the top left graph, it says care management for high-risk patients. What we understand is that as we add a new cohort and they're just getting into some of these pay-for performance measures, they are not going to be as performing as well as our other two cohorts. So you're going to see these little dips because we're bringing on a new cohort. But hopefully by the end of this year, all of those graphs will be going in the right direction, whether that's improvement over self or just improvement in that direction. And it'll be really easy for the practice transformation work group to see or ask questions about the different measures. And then the other thing that we think is really exciting is you can see like the top 10 clinical quality metrics and who is reporting on what. So depression screening and follow-up is at the very top, followed by comprehensive diabetes care. So you can kind of judge within your own organization, oh, well, you know, we're not doing that, or we're doing it a little bit differently, because depending on what your organization is really focusing on, those quality measures might differ. And then in terms of risk stratification, most people are screening social determinants of health now. So whoops, we just lost our dashboard.
Sorry, I got timed out. The dashboard tends to do that for some weird reason.
Anyway, so the point is that we just wanted to show you guys that it's a lot easier to be able to monitor the performance of all of our cohorts as a practice transformation work group. And this is a tool that will help us do fancy schmancy stuff. So if there's a special request at the PTW, we can address that.
There was quite a bit of deliberation to determine what these top 12 measures were going to be. You know, as you know, the toolkit has, you know, dozens and dozens of measures. First of all, they had to be quantitative in nature. Those that were qualitative with text entry couldn't come into the dashboard. But we had to figure out what are the things that are most important that will drive success, the key drivers of success. And Carol highlighted those, you know, the percentage of patients that are receiving care management, the ability of the provider organization to panel patients to a particular provider, follow-up from the emergency department, follow-up from the hospital, types of integration model that they choose, the care coordination options, the way that they risk stratify those patients. So those were based on a lot of internal discussions, the prioritization of the measures that went into this particular tool.
This is Deb. It looks like it's going to be really useful. So great job.
Thanks, Deb.
So we hope to get this rolled out before the end of the month, if not sooner. We've played around with it a lot. We've revised the charts several times, but you should be seeing it hopefully here very soon. Lauren, is there anything you want to say about this?
No, I don't think so. I think you did a great job.
So really, that's all we have for you guys today. That's the essence of the practice transformation work group. And as you can see, you know, we're humming right along. We won't be adding any more cohorts, thank goodness, because we kind of ran out of funding, but 83 sites across our region is a lot to monitor and evaluate. And I think, and I wish that Sam and Martine and Laurel could be on this call today, because there are other practice transformation navigators, but they're unfortunately out of pocket. Sam is in Tennessee attending to a very, very, very sick mom, and Laurel's with a sick son, and I think Martine is out for the day. So Brittany, your newest navigator, is on the line and is eagerly learning all of this stuff so she can help all of our providers through the tough pieces of getting practice transformation under control. And just that's all we have for you. Did you have anything, Brittany, that you wanted to say?
At the moment, I'm just doing a lot of training, so I'm really hoping that here in the next couple of weeks, I'll be able to help with some of these sites. I've been really impressed. I've worked for several organizations, even large organizations such as Providence, and I've been really impressed with the training material that Greater Columbia has. It's very comprehensive. Everything is included. I feel that once I get done with this, I am going to be able to really dive in and be able to help these clinics get where they need to go, so that they will be ready for these quality payment programs, which is ultimately, I know, what we're trying to help them with for their quality. I mean, some of the things that we went through, they have engaged leadership, the quality improvement strategy, that entire chapter, it was very intense. There was a lot to that. I think it was one of the biggest chapters for the training that we had. And that one I really enjoyed. I mean, every single time there was possibly a question, there was a link you could click on, and it would take you to a site or to a YouTube site so you could hear somebody who was talking about it. So been very, very impressed with the training material that has been offered to me, and I feel that it is definitely going to make me be very successful in helping these sites. So I'm very excited to hopefully in the next couple of weeks be able to start diving in and helping getting these people and helping them with their quality metrics.
Thanks, Brittany.
Thank you, Brittany.
We've been kind of, I'd say Greater Columbia has taken a different track with the Medicaid waiver. And I think at first we were somewhat criticized for this approach of investing so much into primary care. But everything that Wes and I were reading and everything that Sam was saying about this practice transformation model, PCMH, it made sense to us. So we just moved forward with it. And what was so interesting, Rick and Deb, last week I was on this phone call with Marianne Lindeblad and Sue Birch. And Sue Birch has been not overly enthusiastic about this approach, but I heard her say, and this was, I almost fell off my chair. She said, you know, we need to be doing this whole program differently. We need to be investing so much more in primary care practice, like Oregon And I was so happy to hear that, because we felt all along that you can't change a healthcare delivery system without investment into your provider organizations. And I think it's really what we're hearing, and we have wonderful stories from Deb, and Rick would love to hear some wonderful stories from Comprehensive too, but we've been hearing some really great outcomes from the funding that's been made available, practices expanding to include more team-based care, adding palliative care to a site, the ability to add on to your EHRs, getting connected with Collective Medical to check for emergency department utilization, relying on One Health Port as a source of information for your clients, being able to risk stratify and understand what, who your patients are. I mean, all of these population health management tools that the navigators help with organizations that aren't familiar with that seem to have been very helpful. And if there's any legacy that Greater Columbia can leave, it's, we hope that the work that we're doing within these practices is helpful to you guys. Otherwise, we would feel really bad if it wasn't. But that's the track we're committed to, and until we hear otherwise, those are the investments that we'll continue to make in your organizations.
Early on in talking with Elia, who was an executive director for Olympic Community of Health, the counterparts of the Greater Columbia, she told me something that really sort of framed up where we're trying to go. And she says, the goal here is to get providers ready for value-based payment. Really, that's it. Which ties in what Carol talks about, preparation using population health management. But in looking at all the tools that we're using, I mean, I've been in healthcare for more than 30 years, and to me, this is really the only evidence-based model that I've come across that will achieve that goal. So personally, I feel very confident in this model. I mean, I think there's, Carol and I think about, other things that we could do. It'd be great if we could provide a bunch of data around the patient summarized across all different payer types, but right now we're not a HIPAA organization, so we can't collect that information and feed that out. But what we can do is on the ground help practice transformation organizations, implement these systems and processes that'll get them ready, have them be better suited for value-based payment contracts.
I am very appreciative of this work.
I am as well, so thank you.
Yeah, thank you.
Well, thank you for your time, and we'll give you back a few minutes of your day. So thanks for joining us, and we look forward to having you guys on the Practice Transformation Work Group.
Great. Now, quick question about the schedule. Are you guys, I have a standing meeting in the afternoons on Thursday. Is this a morning meeting? I see that the next work group meeting is scheduled for Thursday. Is that the 4th? Do you know what time that meeting is scheduled for?
Yes, it's 10 a.m. noon.
Perfect. That'll work for me.
Okay. Thanks, everybody. Thanks, Chelsea.
All right.
Thanks,
Thanks, everyone.
Bye.
Bye-bye.